Good morning, everyone. My name is Al Cannell, I'm president of Strategic Interests, a local consulting firm in New York that helps the whole ecosystem of healthcare transform through innovation. But my purpose for being here goes beyond that. I happen to love healthcare innovation. It's my business. I happen to love New York State, and I'm active in a lot of ways in economic development and other, and I happen to love Israel for a lot of personal reasons. This is a convergence of all three, and we're very happy to bring some amazing experiences on a shift that is going to overtake us. Care in the hospital is amazing. It's also expensive and has a lot of problems, as we've realized. Shifting it to the home is a challenge, but it will have to occur over the next period of years. We don't really know how. There is no roadmap. Some have tremendous experience, and we're going to hear from Sheba Hospital and their experiences, something that will help us all think about how we can accomplish this in our own state of New York. So the New York Israel Chamber of Commerce, HIMSS, and Sheba Hospital have brought this program together, and the economic mission to help share experiences to date, because they've been at this for quite a while. So with that, it gives me great pleasure to introduce Anat Katz, Director Consulate of the Economic Mission of Israel for the Northeast. And I hope you enjoy the session today.
All right, Al, Anat, for some reason, is not on anymore. I'm sure she'll get back on. So I'm going to shift it right over to Dr. Galia, if that's okay, and then we'll get Anat on a little bit later in the presentation.
Terrific.
Okay?
Thank you very much, Nick. Take it away, Galia. Here is Anat. Anat, just in time. Galia is muted.
Okay, hi.
Go ahead, Anat. Anat, I switched it back over to you. All right, I think Anat's having problems, so we're going to go back to Galia. 1 second, Galia, I'll switch it back over to you. Ready? Galia?
Yeah, ready.
Okay. Here we go.
Okay, good morning to you all. We live in an era in which healthcare services are provided beyond the boundaries of health and geographic space. We do that using communication and monitoring technologies, and we call it telemedicine. Numerous studies have shown that telemedicine has the potential to allow not only convenience, but to improve clinical outcomes and save time and money. That is why Sheba, which is the largest medical center in Israel and has been nominated for 3 consecutive times by the Newsweek magazine as one of the top 10 hospitals in the world, has been actively promoting telemedicine programs for the last decade. ARC, Sheba's innovation arm, and its telemedicine hub have developed through methodological collaboration with leading clinicians successful programs of remote cardiac rehabilitation, virtual clinics, physical and neurological rehabilitation programs, psychiatric home hospitalization, and others. The COVID-19 pandemic has obviously affected us tremendously. Sheba was the first in Israel to isolate and treat COVID-19 patients. We decided to seize this opportunity to create a new model of inpatient hospitalization using telemedicine tools to allow the best medical care while minimizing physical contact between patients and staff. This time, the goal was not to overcome distance, but to protect our medical teams. As the pandemic evolved, we faced lockdowns and the need for staff members to stay in isolation. At the same time, there was a softening of the regulation and new modes of reimbursement were applied. This is when Sheba transformed its outpatient clinics to virtual clinics. Telemedicine services grew exponentially. We experienced many challenges and learned from our mistakes. we got over the first COVID-19 wave with a few insights. First, we understood telemedicine is not a constraint, but it can enable us to provide medical services of the highest quality to our patients. We also realized that we have already very good telemedicine tools and platform, which already now we know how to implement and will allow us to scale. And most importantly, we understood that the world, specifically healthcare, is going to change dramatically, and that new hybrid models will take over and will allow us to provide medical services of the highest quality to almost every patient's home. This is when we decided to challenge the term hospital. It no longer has to be a house for sick people, but it can be an organization that takes care of everyone, anytime and everywhere. So at that point, we decided to establish Sheba Beyond. This is Israel's first virtual hospital. I got the privilege to receive this challenge and to establish a kind of a startup company within a public state hospital. In terms of the organization, it was decided that ARC and its telemedicine hub will continue leading the R&D, including exploring new technologies, establishing trials and pilots, whereas Sheba Beyond will be the operational part and will take over mature programs. We'll develop the financial models and we'll find collaborators and partners to widely deploy these programs in order to create new models of care and eventually transform the way we deliver healthcare. For us, hospital at home means bringing all of Sheba's high-level hospital care to each and every patient in the comfort of their home. Therefore, the term hospital at home does not only imply acute hospitalization, but the whole area of services that a hospital can holistically provide at home, such as chronic patient management, home monitoring, rehabilitation services, and of course, hospitalization services. Today, we'll present two different services that have been developed in ARC for the treatment of two very common chronic diseases, diabetes and epilepsy. Both presenters will show us how we can connect clinical excellence to technology companies to create valuable care models in order to transform healthcare. So our first presenters, Professor Orit Chamiel and Dr. Noah Gruber, will share best practices for the treatment of pediatric type 1 diabetes care at home, leveraging Datos remote patient monitoring and telemedicine platform. Professor Chamiel heads the Pediatric Endocrine and Diabetes Unit in the Safra Children's Hospital at Sheba and the National Juvenile Diabetes Clinic in Maccabi Health. Her research interests are within the field of type 1 and type 2 diabetes mellitus in children and adolescents, obesity and eating disorders. Professor Chamiel has published over 150 articles and chapters in textbooks of endocrinology. She's a member of the editorial board of Pediatric Diabetes, and she was lately awarded the European Society Pediatric Endocrine Outstanding Clinician Award for 2021. This is very prestigious. Dr. Noah Gruber is a senior pediatric endocrinologist, consultant in the Pediatric Endocrine and Diabetes Unit, and a senior physician in the pediatric department. Her main fields of interest and research are reproductive endocrinology and diabetes technologies. She focuses on studying methods to improve the metabolic control of children with type 1 diabetes. Professor Chamiel and Dr. Gruber, I'll pass it on to you.
Okay, Lee, you have to turn on your screen so I can. Okay, you're on.
Gaia, thank you for your kind introduction, and we will start in a minute. Here we go.
Okay, so thank you. Good morning, everyone. Here in Israel, it's already afternoon. My name is Noah Gruber, and I'm a pediatric endocrinologist. And together with Professor Orit Pinchas Chamiel, who is the head of the Pediatric Endocrine Unit in Sheba Medical Center, we would like to talk to you about telediabetes. So first, we'll shortly discuss type 1 diabetes, and specifically the diabetes technologies, and then what were our challenges in this field, how COVID-19 and telemedicine in COVID-19 era help us find the solution, how other solutions had inspirations for us and our solution. Type 1 diabetes mellitus is a lifelong disease affecting children and adolescents that can ultimately lead to significant morbidity. The incidence of type 1 diabetes has been increasing. Treatment of diabetes poses unique challenges. Current treatment is intensive and includes multiple daily injections or insulin pump treatment, frequent self-monitoring of blood glucose, dietary modifications, and physical activity adjustments. The DCCT clearly demonstrated the benefits of good glycemic control in individuals with type 1 diabetes. Immediate risks of mismanagements include hypoglycemic events and associated cognitive sequelae on one hand, and on the other hand, hyperglycemia and diabetes ketoacidosis, or DKA. Long-term consequences of uncontrolled diabetes include microvascular and macrovascular disease. And despite the technological advancement in the field, poor glycemic control continues to be a major problem among youth with type 1. Results from the Type 1 Diabetes Exchange Clinic Network, comprising of around 13,000 participants, revealed that overall, only 1/3 of the patients met the targets of the ADA. Deterioration of glycemic control typically occurs during the adolescence years. So exactly 100 years ago, insulin was discovered, and we all celebrated it. The first insulin pump prototype was invented in 1963, but luckily today we have smaller and much more compact insulin pump devices. Also, the continuous glucose monitoring systems, the CGMS, where the patient could see his or her glucose levels all the time, are also smaller and compact, as you can see in the pictures. We also have what we call artificial pancreas, or closed loop, where the insulin pump talks to the CGMS and insulin could be stopped or infused according to the glucose level. Our patients, and some of our patients already do what is called do-it-yourself. They, by a pirate way, connect the insulin pump to the CGMS, and then they could talk to each other. So according to standards of medical care for individuals with type 1 diabetes, interval follow-up visits should occur at least every 3 to 4 months, individualized to the patient. The medical visits are used to review diabetes care plans and change them as needed, and also for patients' education and empowerment. But tracking the origin of this recommendation is difficult. If we look at a child's daily life with type 1 diabetes, his glucose levels is like a roller coaster. In the left panel, you can see on the y-axis the glucose level, and on the x-axis the time of the day, from midnight to midnight. And here you can see 14 days along the day of a child with diabetes, and one day is high glucose, and then some hours afterwards low glucose, and it's like a roller coaster. And when we come at the medical visit to actually change the diabetes care plan, we have to data mine. I mean, if you look at the left panel, you can see the graphs of the glucose levels. The dark line is how much carbohydrates were inserted for each meal, and the lower panel is how much was given for each meal. But actually, you really have to look at all of the picture, because the glucose levels are not influenced only by the food, but also by physical activity, stress, illness, all other variables. On the right panel, you can see the insulin pump care plan and how we have to, as I said, to data mine in order to understand how to manage the diabetes. So when the lockdown secondary to COVID-19 came, it enabled us to access telemedicine. Datos Health is a provider of hospital-grade telemedicine patient management platform. And when COVID struck, the platform rapidly expanded for remote monitoring in Sheba's COVID telemedicine program. Professor Orit Pinchas-Chamiel led a trial, which was a multi-center trial, an observational real-time study, which retrieved the CGMS and insulin pumps data 2 weeks prior to a telehealth visit and 2 weeks afterwards. Around 200 patients were in this study, with a mean diabetes duration of 6 years, mean age of 14.6 years. And this study, from this study, we learned that glycemic ranges improved significantly following the telehealth visit. The percent of time in range increased from 59 to 63%, and only after 2 weeks, right? The percent time spent in severe hypoglycemic and hyperglycemic ranges decreased significantly, and also the estimated hemoglobin A1C decreased from 7.3 to 7.2. So this study taught us that we can we have telemedicine, and telediabetes specifically is efficient in the management of diabetes. At the same time around that, Professor Robert Klempner, who is the head of Sheba's Cardiac Rehabilitation Institute, together with the ARC Innovation Center and Datos, they established a virtual cardiac rehabilitation program, which includes the supervision of a multidisciplinary team, a designated phone app that includes a step counter and personal training schedule, as well as a smartwatch. Medical team provides feedback such as reminders and encouragement, and alerts to any irregularities in the monitor data are flagged by the program. Together with us understanding that the life of a child with diabetes is like a roller coaster, and that every 3 to 4 months is not enough in order to change and improve his diabetes control. And on the other hand, every 2 weeks is a lot of workload and requires data mining of the medical staff. We thought to create and develop a smart alarm system. So together with ARC and Datos, we created a targeted technology platform that receives the CGMS data. We developed a specific platform to monitor and optimize the management of type 1 diabetes. A designated phone application was developed to scan the glucose levels from the patient's CGMS. This system detects extreme situations of blood glucose and sends alerts to the patient's and their family's phone periodically, not in real time. Different alerts are flagged by various colors on the staff's clinical dashboard, and based on a developed algorithm, the case manager of the program contacts the families, and if needed, the medical team interferes. So we have the patients with the type 1 diabetes who wear the CGMS and the insulin pump. Data are transferred by telehealth. Using a designated phone application, the patient scans the glucose levels with the CGMS. Automatic alerts are sent to the patients and their families regarding high or extremely low glucose levels. Feedback are sent every 1 week to the patients. The patients also wear smartwatch, which measures the pulse, the number of steps, the physical activity, and the sleep hours of the patient, and questionnaires regarding the quality of health, the quality of life, the fear of hypoglycemia, etc. are sent to the patients. And at the end, advice are sent by medical team. So our telediabetes team is actually the patient and his or her family are in the center. The case manager in our hospital is a certified nurse who actually sends the alerts are sent automatically, and according to special algorithms, she reaches out the patient. And according to these algorithms and according to her decision, she sends the other questions to the dietitian, to the psychologist if needed, to other nurses or the doctors. So the Daily Diabetes Dream enables us to improve quality of life, improve diabetes care, improve diabetes control, reduce DKA, reduce severe hypoglycemia, reduce diabetes complications, and increase telehealth access. We would like to thank, first of all, the pediatric endocrine unit team who helped us put up this special and important project. We would like to thank the ARC Innovation Center, led by Professor Eyal Zimmerman, to Dr. Gali Barkay, who leads the Sheba Beyond First Virtual Hospital, to Ms. Iris Stein, who helped us with this project, to Professor Robert Klempner, who was our inspiration, to Datos team, who helped us develop this program, and especially, and most importantly, we would like to thank patients and families for teaching us how to be better doctors. Thank you very much.
Perfect.
Thank you. I believe now we have Dr. Hamel and Dr. Gruber. Is that correct?
We are those that, yes, Dr. Mia and Dr. Gruber, we are here.
Okay. And your presentation? Oh, you just finished. So
That was the
questions?
presentation.
Yeah.
Yeah, we just finished. Do you want us to call Dr. Nicole?
We have no questions from the audience at this time. So if you want, we can move on to our next presenter.
Oh,
Let me present Dr. Professor Nicola Maggio. Can you hear me?
Yes, we can.
Yes, of course.
Okay, so our next use case of applying technology to better monitor and treat chronic patients will be presented by Professor Nicola Maggio, who will share best practices in elevated monitoring and adherence for patients with epilepsy at home, leveraging the iRODI platform. Professor Maggio is Deputy Head of Neurology Department and Director of Epilepsy Service. He will discuss the dynamics of working together with Eyal Bautfeld, CEO of iRODI. Thank you.
Okay, thank you, Galia, for the nice introduction. I'm joined in my presentation by Dr. Eyal Bautfeld, who is the CEO of iRODI, which is the platform that allows us to digitalize our practice in a setting of a hospital at home. Before I go forward and present you the plan, I want to share with you a statement that I think it's very important, and is actually that digitalization and the hospital at home concept allows us to change the paradigm on how we practice medicine, because usually we are used to have a patient that comes to the clinic every once in a while and tells us what he has experienced, he or she has experienced. But now, with digital revolution, we are able to follow these people, in their home setting, and eventually leave their disease according to what they feel. Okay, so this is something totally new that we can experience, with this kind of settings. Okay, so I'll move forward. So do I go forward? Okay. So we choose, epilepsy is a known disease, is actually the third most common neurological disease. The prevalence is 1.5% of the global population are affected by these disorders. Only in Israel is 86,000 patients. On the other side, there are patients that have experienced only one seizure in their lifetime. They do not know at the time of experience that they will have only a seizure, that's what their experience is. So these are all patients that they need to be followed up at least for 1 year in order to see that this is indeed has been a single seizure and not, epilepsy, which is recurrent seizures. The percentage of people that are affected by one single seizure because of any kind of etiology, so it's 9%. So in Israel is about 780,000 patients. So those people, either the one with epilepsy that have this experience recurrent seizure, or those with a single seizure, which actually they do not know yet that they are not epilepsy patient, they have in common in their follow-up their first year. Actually, the first year since the first seizure is a critical time frame by which both patients, they actually experience, the possibility of doing tests, MRI, EEGs, at least 3, possibly video EEGs. Eventually, we need to take care of a seizure rate if the seizures are upgoing, then there can be a diagnosis of or epilepsy in people that have experienced only one seizure or drug-resistant epilepsy. And this is also the year where psychological issues or social issues related to disease arise, and they need also to be addressed by the care team. So if we look at this first year of care, then we understand that this first year of care requires continuous involvement from the care team, both on-site, okay, their home. So here there is a challenge, which is improving the disease management and achieving a better care and a timely, effective intervention. There is also a technological opportunity in this first year, which is the possibility of creating a hybrid integrated program that can eventually bridge a digital and the face-to-face treatment environment. And there is also a vision, which is based on improving the telemedicine-based disease management and care on a global scale. And here it is our approach, which is basically to combine the efforts of an integrated practice unit epilepsy care team together with a high-tech company, which is iReady, which basically developed a system, a digital assistant management software, which can allow a better follow-up patients and a better care management of these people. So what we try to do is to recruit at least 50 patients, in order to see whether this practice can eventually change our way of thinking and our way of managing this disease. The point of recruitment is the time of hospitalization. This is actually the time where the patient are facing physicians because they have experienced their first seizure. Okay, the monitoring is done by a case manager who is using this digital assistant software developed by iReady. The clinical consultation, which is both face-to-face or digital, includes 3 physician visits, 2 psychological visits, 3 social worker visits. And at the end of this 1-year program, eventually the patient can renew their plan or eventually, shift towards a common face-to-face only setting. So if we look at the patient journey, so we have the patient, which can eventually inform all the time about seizures, medication side effects, comorbidities, medical tests performed, the case manager. So the patient and the case manager can interact all the time using the iReady platform. The case manager provides assistance to the patients within 24 hours. So the patient feels all the time that there is somebody, which is engaged in his care. And eventually, if there are questions that he doesn't know how to deal with, he can directly transfer them to the other, members of the epilepsy care team, which are either physicians, psychologists, and social worker, which they can also, they also use the iReady and be in touch directly with the patients if the patient has a specific question. The system is important also for the face-to-face visit at the time of the epilepsy clinic, at the time when patient walks in, because eventually the patient with this app, with this platform, come to the clinic, and eventually the team can refer and act based on the insight that he got with digital data, for example, on seizure, as well as side effects on medication, which are delivered timely by the patients, on recognition of the patterns of seizures based on triggers, assessment of therapeutic outcomes, or reported the effective emotional implication or social and family issues. So we actually, the expectations are that there a better patient care based on data delivered medicine directly and timely reported by the patient, improved outcome for patients upon possible visit at the emergency room, a faster scheduling of procedures and tests in Sheba for recruited patients. Recruited patients are bound to Sheba because they are less prone to go somewhere else, because they are bound to us already with this platform, and a better time management of the care team at the hospital. So here is just some scheme in order to show you basically the engagement the patients have already with the application. Total activity days are the days where actually the patient have interacted with the application at least once in a day. The total days having seizure or seizure-free information, they actually actively, push a button in their phone to inform us either that they have had a seizure or not. And eventually, you can see in the pie graph, the type of interaction that we have with the patients. They can monitor, they can tell us even when they go to sleep, whether, they took medication or not. So actually, this system allows a better interaction with our patient towards, a better management. I just, want to say that this is actually the first step in order to possibly, allow all the neurology subspecialties getting into digital transformation towards the application, the IRD platform that it has been developed. So many thanks to you.
Great.
Okay, sorry. So 1 second, just last, I forgot.
Yeah.
So the insight that actually we have to date is that there is patients that value communication with the care team. So I showed you that the engagement of these patients, and the digital remote patient care reveals gaps in the care. So pill strength, they are purchased, but may be different from the prescriptions. So that's what we saw. That actually patients sometimes take medication, but they basically forgot that basically, how they should schedule, their dose. That patients maybe they can be confused, and with this platform we can reduce compliance. That's it. So many thanks.
Great.
Thank you.
We do have some questions, and I'll be glad to ask you both. Since you were recently just speaking, University of Rochester happens to be a center of excellence in neurological disease, as does NYU, two of our prominent academic medical centers. Where does the continuation to other neurological diseases beyond this really come into play? Multiple sclerosis, Huntington's disease, these are all potential. Are they on your roadmap at all?
Yeah, so what is in the roadmap right now is migraine, headache, migraine. We have already established, the seeds, let's say, for movement disorder. And eventually, later on, maybe also neuroimmunology can get in, but eventually the first one, that they will get in are migraine, headache, care, and movement disorder.
Right. So movement disorder being Parkinson's and Huntington's both.
Yeah, exactly. Yeah,
so
exactly.
Please keep the University of Rochester in mind and NYU as those become of interest. And on the diabetes side, there was a question about going from type 1 to type 2. When and where and how significant is that change? And will there be as much value, do you think, attained as you add that population? Because it's a much bigger population.
So we are pediatrician, and type 2 diabetes is not really a problem in adolescents in Israel as it is in the United States, but we believe that if adult or young adults with type 2 diabetes have the technology and they have the continuous glucose monitoring sensor, the same approach is really will be working as good. And even in the type 2 diabetes, I think that they can even control their eating habits. And so it will be even another extra to this program. I think it will be perfect.
And there are other innovations from Israel, like Day 2, which are there to help monitor diet, to address glucose levels. So, you know, being able to personalize your care seems to be very exciting. Okay. Any other questions coming in? If not, oh, I see that Galia would like to speak. You're on mute. Go ahead, Galia.
I'm still on mute.
No, we hear you.
Oh, you hear me? Because I'm trying to unmute and someone mutes me again. Yeah, so Professor Chamiel and Dr. Gruber represent the pediatric endocrine unit, and we do have in Sheba type 2 diabetes using the DATOS application for adults. And we do have a clinic working, treating type 2 diabetes patients, adult patients. So it is applicable for adult patients with type 2 diabetes. Definitely a larger population in adults, at least.
Great. Another question from the audience is, are there any drawbacks? Oh, and are there any drawbacks to the digital program? Are we missing anything by not being in person? Of course, it's not always as good, but I think you're applying it where you lose less. But if you could answer that question, that would be terrific.
Well, it's not instead, it's on top of. It's at least in children and adolescents, it's not instead. What we're trying to point out is that a visit every 3 months is not enough. And we want to be on top of the things closer. So it's not instead. Many patients don't come to their visits because of their daily routine problems. And in this way, we can be in contact more often. One of the things that we are studying now is if we don't exaggerate. If an adolescent will say, you know, every 2 weeks is too much. Maybe once a month is enough of having the medical team on my back. And these are the things that we try to monitor and to see what will be the best mix of for money to be with them and then not to override. Yeah.
Terrific. While we're waiting for more questions, I will say that I have quite a few friends, close friends that, you know, have, or their kids that have type 1 diabetes or epilepsy, and they're terrible diseases. So anything you could do to make it easier to give care to these people, they will seek more care if it is easier. And I want to pause and say, Galia, sorry about managing the mute button, but now you know how I feel. People are trying to mute me all the time, especially in my house. But I will say, I want to come back and say that Israel is an amazing country. I've been there many times, and it's a source of incredible innovation and advanced tech. You saw some of that today, especially in healthcare. The technology in sensors, AI, ML, wearables, computer vision are being applied in so many innovative ways, some of which you saw today, and bringing it together in applications that have a long-lasting positive impact on care. Personalized medicine and hospital in the home are next, and Israel's leading the way and right at the forefront. HIMSS, an amazing organization, exists to help healthcare professionals be better through education, conferences, sharing best practices, and convening to address tough issues like we did today. State chapters do it on a more intimate basis, and I've been lucky only in the last year or so to be active with the New York State chapter which has graciously done a lot of work to bring in a new kind of program here today. And it was quite an experience to do so. They have more intimate events. There are many education opportunities, and we hope that there'll be lots of opportunities for other amazing breakthrough technologies from Israel and other parts of the world to be brought to the members of New York HIMSS and other chapters. So we thank you for cracking the code on how do we align these two organizations to be able to share these best practices with the nation. And by the way, it's not just New York. We've opened this up to others as well. So I thank you for that. We do have some more questions in the meantime from Paul Borneman. This would be an interesting one. How do you overcome connectivity issues in communities without cellular or broadband? And I hate to say it, but it's less of an issue in Israel than it is in the US. But please address that, because there are some areas that don't have as much broadband. So go ahead.
Would you like me to answer? So we indeed in Israel we have broadband everywhere, and everyone has a digital or a smartphone. But for some of our programs, for example, home hospitalization, we will provide them with a tablet and a special SIM. They don't have to have internet in their houses or a special device. So for some of the programs, we do provide the devices and the connectivity that's needed. But it is an issue, I think, that should be, taken care of in a global level. How to increase accessibility of telehealth to everyone on the globe. And this will take time, but it's definitely something we need to do.
Great. And we in the US has, oh, go ahead.
I just wanted to add that this helps us to give actually service to places in the world that they don't have their own clinics. So we were able to give to children in Africa that made connection with Sheba. We follow them and we can see them this way, which could never be otherwise. So it's another phase of this service, yes.
And in the US, the federal government has given away a lot of money and will continue to give more to shore up broadband and access in underserved areas, rural areas, urban areas where even though there's you'd think cell is not a problem, it is in wireless. So I'm glad to hear that you're working on that. With regards to one of the challenges, oh, go ahead, Eyal.
Yeah, I just wanted to mention that from a technology perspective, the devices are set so that they keep the information on the device until an internet connection is available in any sort. And at that time, they move the information over to the care team. So the information is not lost, even if there is no internet connection of any kind at the patient's home.
That's good to know. So another question we have is, the technology is one thing, but in for amazing breakthrough technologies to be installed, implemented, deployed, and effective, it requires change in process and change in perspective on the users and change in workflow, not to mention things like links to the communication center or, the admin processes for patients. How do you sort of encourage smooth adoption beyond just the technology?
So as I learned, I'm a physician originally, and as I learned in the last few years, the main issue in these things is integration. So it's really hard to integrate different systems. It's easy to use one technology and to teach some physicians and maybe some patients, but the integration is the major issue. And I think this is one of the reasons why we decided to create this organization that we call Sheba Beyond, because what we do is we're specializing in taking all the healthcare professional of Sheba, all the the knowledge, the greatest physicians, the greatest medical knowledge, to combine it with technology through ARC. And what Sheba Beyond does is finding the new models of treatment, finding the new collaborations, working outside with the Ministry of Health, with regulation, with the clinician, and we have to, make all the stakeholders work together. I think this is one way to do it, is to create an organization that's focused on doing all these things together. So it's a big challenge, but we're addressing it.
That's terrific. And the U.S. also has the Office of the National Coordinator, which is focused on establishing both frameworks and tools and capabilities for sharing that interoperability and integration. And so we and many other people on this call, in fact, HIMSS has events just on that. And now there's laws that say you must open up, hospitals and insurance companies must open up and be able to share their information, something that didn't exist before. And so I have been to Israel and saw DB Motion in place in, I believe it was 2003 or 2004. And so they have a national healthcare system that is phenomenal. It's easier there because there are 4 HMOs and everybody belongs to one of them, and everybody has a PCP that's part of one of those HMOs. It'd be like if the US was Kaiser Intermountain, UPMC, and Geisinger, right? Mm-hmm. But we don't have that. We don't have that luxury. But the lessons learned from DB Motion and you can be applied here. Just be aware, we have a lot of other challenges to get that integration accomplished. It's not as easy. And of course, we have a large number of vendors, the Epics, the Cerners, the Athenas, that are very good and very prominent, where you have a smaller number of systems there. But it's problems that we're equipped to handle with organization like HIMSS. Okay. I see another question. Oh, it's just appreciation of the topics used for these two populations. So thank you. There are many other populations we can do. I would like Anat to say a few words, and then I want to come back and ask the audience to give us opinions about either other diseases or topics we should cover in the future while we have people on the line. So Anat, welcome back.
Okay, thank you, Alan. Thank you, everybody. It's really a great pleasure. I was supposed to actually say a few words in the beginning, so, I prepared welcoming notes, but, closing remarks are just as great. So thank you, everybody. Just a few words about myself. I'm Israel's Economic Minister to North America. And our office, Israel's Economic and Trade Mission, what we do is that we help connect Israeli technologies and innovation and best practices with US companies and organizations and investors and all the other stakeholders that are they basically need them. So we act as a bridge. And I think that today it's been a very good example of this type of activity, of knowledge sharing. We work both with the Israeli side, helping the Israeli organizations and the companies identify the opportunities and make the connections. But I think it's important to mention that we also help directly the US side. We often engage with hospitals and organizations, investors, and we scout for technologies. We organize knowledge sharing experiences such as today, and we also facilitate direct contact between the parties. And I think that over the years we have seen much success in connecting brilliant people from Israel with equally brilliant people from the US side. Today, we heard from Sheba's ACR, Sheba Center, that works to accelerate, redesign, and collaborate in digital innovation. I think that this has been a fantastic example of some of the work that has been done during the pandemic that basically brought all of us, and made the need to work from home and provide home care even much more prominent. And we heard a number of examples. I would like to thank the doctors, the researchers. I know that even trying to do a dry run was so difficult and challenging because these people are actually so busy providing the actual care to the patients. And we heard that they're doing this in Israel and beyond. I'd like to thank HIMSS for being such a great partner in organizing this event, and I hope that we will have many, many more to come. I do want to draw everybody's attention to the fact that not only are we doing online events, we have 28 Israeli companies that will be visiting HLTH Health exhibition in Boston coming up. Now this October 17th. We'll be there. This is digital health. We work directly with hospitals and everybody else who's interested in getting more information and potentially meet with them. We'll be very, very happy to make this connection. So just really to close, thank you very much, Sheba, from Sheba's side for organizing this event. She has been super as always, and thank you so much, Nick, Al, and all the colleagues from HIMSS. If anybody has any kind of question or would like to follow up with any of our researchers or with Sheba hospital in general, please feel free to reach out to us, and we will make this connection. And with that, I return it back to you, Al, to, I assume, close this, unless there are additional questions.
Well, there was one other question, but beforehand, I think I mentioned in the front, so New York and Israel, there's a lot of connections there, and we helped further that with regards to healthcare today. There is another entity, the New York Israel Chamber of Commerce, represents the whole state, and will work closely with Anat, and I've been given the pleasure of being on the board of that organization now for the past year. And it is a wonderful organization, and life sciences and healthcare is one of the areas of focus. So please do not feel shy about reaching out to Anat or Josh. I put Josh's email in the chat and mine as well on ways, either way, that we could do collaboration. And by the way, Israelis love to learn as well. So Americans that have great innovation and best practices, it's not a one-way street. So we'd like to open up sharing both ways. That's what HIMSS is about. It's not one way. We do have one last question, and that is, it seems that many of these programs are more valuable when somebody's responsible for the entire cost of care, like an HMO, like a Geisinger, like a Kaiser, like the HMOs in Israel. But some are also valuable, and our payers, our health insurance companies, going to be willing to pay for some of these capabilities. And you don't really know our health system, but if you could maybe talk a little bit to what you see the value to Maccabi and Clalit and the other HMOs, that would be great. Looks like Galia froze. Oh, there you are. So any thoughts about the value of these programs in reducing the cost of care?
Yeah, so it will take us some time, but we'll have to show the HMOs that we can reduce hospitalization, we can reduce usage of medical things. So we'll have to show them that using these services, it will decrease cost eventually. But diabetes type 1 is a good example, because I think the consequences, the sequela, happen many years later on. The complications will happen later on. And it's much harder, I think, to show it to the HMOs when it's not right now. For example, epilepsy, if you can decrease the number of hospitalization because they have less convulsions and seizures, it's easier to show, or in other elderly chronic diseases. But I think what we do now is that when we start to develop what we do in Sheba Beyond, we start to develop a new program, we go and talk to the HMOs, and we develop it many times together. And we will ask the HMOs what are their needs, in which cases they have difficulties of taking care of the patients by themselves, and they feel that they can get extra value from us, the hospital team. And many times we will do it together, and will not go further to develop a treatment plan when we think the HMOs will not want to use afterwards. So we work in collaboration in Israel. As you said, it's simpler because we only have 4 HMOs, and one of them has its own, Clalit has its own hospital. So we work mostly with 3 HMOs, and we will work in collaboration with them to find their needs, to track their needs and to develop together something that meets their needs.
Great. With that, if there are no other questions, we'll be sending out a survey to get feedback, because this is the first of many, so we can, in the spirit of continuous improvement, and we'll include in that an opportunity for you to share areas where you're interested in either particular technologies or clinical conditions. But I, from the bottom of my heart, want to thank the folks from Sheba, the Economic Mission, HIMSS, and the New York Israel Chamber, and all of the attendees who took time out of your busy day, 55 minutes, so we gave you 5 back. Thank you very much.
Thank you.
17, 12, 98.
Thank you very much.
Thank you.